First part of my talk will be about delayed endovascular repair of blunt thoracic aortic injury. As we know from the U.S. statistics, it is estimated that approximately 8,000 deaths are associated with this type of condition. It is also the second most common cause of death in blunt trauma patients. Majority of these patients die at the scene from massive exsanguination, and it's estimated that only 10 to 15% of these patients make it to the hospital with signs of life. So most common mechanism of this injury is motor vehicle collision, followed by pedestrian struck by vehicles, and by a fall from heights. Aortic isthmus is a classic site of blunt aortic traumatic injury, and there's a variety of pathological mechanisms that lead to this devastating problem. So there's a water hammer stress, along with a torsion stress in the ascending aorta. There's bending stress in the distal aortic arch, with shearing stress in the descending aorta and at the level of aortic isthmus. There are 4 grades of aortic injury, starting with a minimal intimal tear through grade 2 being an intramural hematoma, with grade 3 presented by a pseudoaneurysm, and grade 4 being a frank aortic rupture. Surgical approach to the repair was historically emergent open surgical intervention. However, mortality rates were up to 30%. With the advent of TEVAR, we found out that this offers a significantly lower risk of death and spinal cord ischemia, and this is seen in all age groups compared with open surgery. So, current recommendations for the previously mentioned Society for Vascular Surgery recommends or suggests urgent repair in less than 24 hours in patients with this type of a problem. To Westchester Medical Center, which is the institution where we practice, which is also a level 1 trauma center, we observed that aortic repair that occurs over 24 hours from the time of blunt injury in hemodynamically stable trauma patients is safe. And as a result of it, we adopted a strategy of delayed thoracic endovascular repair for blunt trauma injury for these patients. We reviewed our data with the institutional approval of a review board. We had 28 patients treated with TEVAR for this type of problem over the span from 2006 to 2015, and 14 patients from the initial period were analyzed. CAT scan diagnosis was performed in all patients. Aortic arch involvement patients were included in this treatment, and endovascular repair was done in accordance with the device instructions for use. So blunt traumatic aortic injury patients were looked at and classified to hemodynamically unstable, and if found such, they underwent either emergent TEVAR or open repair. However, if patients were hemodynamically stable, we focused on stabilizing other injuries, and we controlled blood pressure as well as rate. And we elected to go with a delayed TEVAR in this patient population. So these patients were young, 48 years of age at the mean. There were more males than females. Mean injury severity score was high at 37, and mechanism of injury followed what was previously described, with motor vehicle collision being the most frequent, fall second most frequent, and pedestrian struck as the last. So these patients had a number of associated thoracic injury with rib fractures, pulmonary contusions, pneumothorax, hemothorax. They also had a large number of extrathoracic injuries, and they included predominantly neurologic injuries, followed by orthopedic injuries, those long bones as well as spine, intraabdominal injuries, and head and neck. Location of injury was in the descending aorta at the aortic isthmus in majority of patients, and then one patient had a diaphragmatic hiatus injury. Aortic arch was involved in 2 out of 14, and we did not see any patients with ascending aortic injury. So what about timing of repair, which is the main part of my talk? So out of 14 patients, One patient required emergency repair, and this was because this patient had hemothorax with hemodynamic instability. Interestingly, this patient continued to be hemodynamically unstable after stent placement and underwent open thoracic intervention and was found to have active bleeding from the injured intercostal artery. Upon repairing that, the patient became stable. In the remaining 13 patients, however, we elected delayed TVAR, and please note that the mean time to repair was 31 days, with the median time of repair being 30 days. The longest repair patient lasted 113 days in the hospital before we intervened. And finally, these were our operative times. Please note that this does not include just pure operating time. It's also getting in and out of the operating room. So we used these stent grafts, with Talent being most frequently used, Igor being second, and Angiogram was used in one patient. We used one stent graft in 12 patients, and 2 patients required 2 stents. Initially, we operated with a portable C-arm. Later, with the addition of hybrid OR, we moved all our cases to the hybrid OR setting. As far as intraoperative imaging, this is one of our cases. It's a young patient with clearly seen aneurysm at the aortic isthmus. This is a stent graft in place with initial deployment of flowering. Please note the presence of the left subclavian to carotid artery bypass. We do believe in routine revascularization of the left subclavian artery when we need to cover it. And this is a stent in place with excluded pseudoaneurysm of the proximal descending aorta. We do intravascular ultrasound. We use it for localization of the injury. We also use it for sizing purposes. We find that there is a lot of variation, especially young patients, in the diameter of the proximal aorta. And we try not to oversize in these patients. So we use IVUS for precise measurements at various parts of the proximal landing zone. And we use our systole and diastole measurements for a selection of graft diameter. So as far as our results are concerned, interestingly, type 1 endo leak was seen in 4 patients. This resolved successfully after balloon angioplasty of the proximal landing zone. Of note, this is not something that we do routinely. One patient required additional stent graft. There were no type 2, type 3, or type 4 endo leaks. Left subclavian artery was covered in 7 out of 14 patients. The bypass was performed in 3 patients preoperatively. One patient had a cabbage with an internal mammary artery graft, and 2 patients had a significant coronary artery disease and felt that we had to preserve this artery for future interventions. So there were no intraoperative mortality or no open conversions in this patient group. We observed no stroke, paraplegia, arm ischemia, myocardial infarction, bowel ischemia, or renal insufficiency. One patient did have transient loss of lower extremity pulses that recovered with systemic anticoagulation that was felt due to basically low blood pressure intraoperatively transient. One patient had empyema that required video-assisted thoracic surgery. So within 30 days, we had 0 mortality that was related to the stent. We also had 0 stent-related morbidity. Type 2 endo leak was noted in 1 patient during the first 30-day follow-up, and was controlled via embolization of the left subclavian artery. So I'd like to conclude that a routine delayed repair of blunt traumatic aortic aneurysm with TVAR is safe in hemodynamically stable trauma patients, and this approach allows for treatment of other life-threatening injuries first that may lead to improved patient survival. However, further studies are needed to look at that. I'm going to move on to my second part of the talk, which are some of our challenging aortic interventions. The first case is a patient with symptomatic and increasing in size penetrating aortic ulcerations with worsening back pain. This is a case where he has occluded right common iliac artery and severely stenotic and calcified left common iliac artery. And we approached it in previously presented antegrade TEVAR via mini sternotomy in the ascending aortic cannulation. What's different in this case is that we chose this approach for a patient that did not have a pathology in the heart or ascending aorta or aortic arch. So this is his initial CT angiogram and 3D reconstruction. One can appreciate actually multiple penetrating aortic ulcers in a descending thoracic aorta with very diseased aorta, and occlusion of one common iliac artery and severe stenosis of the contralateral common iliac artery. This is our intraoperative picture with the first left upper corner photograph showing mini sternotomy, second showing an introducer wire and the sheath in the ascending aorta, and then on the third picture we have insertion of the large sheath, and then finally the sheath in the position with in the ascending aorta right below the beginning of the aortic arch. So for this type of approach, we use multidisciplinary collaboration. We have cardiothoracic surgeons, interventional cardiologists, as well as vascular surgeons present in the room. In this particular case, we used 2 Cook stent grafts of varied diameter, with the small diameter being deployed first, followed by the large diameter telescope into it. We do use rapid ventricular pacing. We use it for optimization of the deployment accuracy and a stent stability during the deployment. This is the initial angiogram from the lower part of the body to the pigtail. This is the first stent in the position with a distal stent deployment. One can appreciate a large penetrating ulcer. This is the proximal stent deployment, the stent going higher up in the distal aortic arch. And then this is the final completion angiogram. We have full successful exclusion of aortic ulcers in the descending thoracic aorta. Our second challenging aortic case is an abdominal case. It's a 70-year-old man with very large bilateral common or iliac artery aneurysms. Interestingly, this patient had a previous repair, open repair of iliac aneurysms 23 years ago with a hemischilled aorta by iliac graft. This is this patient's initial angiogram, CT angiogram with 3D reconstruction. One can appreciate really massive size of these 2 aneurysms. I'm not showing the actual operative angiogram because it was very unrevealing. There was minimal flow into these aneurysms, and our visualization initially was very poor because of contrast dilution. In this patient, we wanted to preserve flow to the pelvic floor. We wanted to preserve one of his hypogastric arteries, and we did not think that this is a patient for open repair. So we chose an endovascular approach with main body of the graft deployed from the left side and left hypogastric artery embolization. Once the main body was in place and partially deployed, then we accessed the right hypogastric artery from the left arm. This will become much clearer as the pictures will come in. And then we placed Viaband stents from the left arm to the right internal iliac artery for flow preservation. And finally, we ligated the right external iliac artery and performed left to right femoral to femoral artery bypass. So this is our main body stent in place with the right hypogastric artery cannulated from the left arm, Viaband stents already in place, and one can appreciate flow to the hypogastric artery, internal iliac artery on the right, with cross flow to the left side. This is embolization of the left subclavian artery, and actually this is after the deployment of the extension into the left external iliac artery, and ballooning of that stent segment. And this is our completion angiogram, stent in place, preservation of flow to the right hypogastric artery, and flow to the left external iliac artery, and a fem-fem bypass is not visualized, but it is in place. Thank you very much for your attention.
Just one short question. Why did you decide to delay the intervention in those patients with aortic implant trauma?
Well, it's an excellent question. The delay is because frequently these patients are multi-organ injured patients. They come in predominantly with intracranial injuries, long bone injuries, intra-abdominal injuries, and they have ongoing bleeding. They require stabilization, and they're hypotensive. And as the result of it, they're not ready for this type of intervention. So by basically approaching these patients with initial management of their potential hypertension and tachycardia, we buy ourselves time to address all the other remaining injuries. We frequently see that they go on and develop respiratory issues, ventilator-related pneumonias, they're infected, they have positive blood cultures and whatnot. So even in the later time period, when they stay in the intensive care unit, they're not stable enough to have these type of interventions. So by approaching it, we actually show that in these initial 14 patients and 14 patients in the second half of our study, we do not risk anything in it. We can really achieve better patient stabilization and still repair these pseudoaneurysms before patients are discharged from the hospital.
Thank you.